inviting me. So I'm going to talk to you this afternoon about a repurposed drug, metformin, in a rare condition, tuberous sclerosis complex. And I think the journey is quite interesting and fascinating. So you probably heard of metformin previously, and it has a really interesting story. This drug has been around for more than 100 years, and it has changed over the years the way we have been using it. Initially, it was found to work as an anti-malarial drug or antiviral, and people were using it like paracetamol as an antipyretic and analgesic. But it then changed over the years. And then it was found to be effective in diabetes, and people, because were having this particular plant and realized that it was working on their urinary system. As you know, if you have diabetes, and if your diabetes is not well controlled, you pass a lot of urine. But if your diabetes is well controlled, then you can control the urinary symptoms. So people were taking this plant and realized, oh, it's working for them. There must be something in this plant. Then they realized it was the metformin compound, and it became available for people with diabetes. But it then changed. It lost its reputation because we discovered insulin. And then in some countries, metformin was completely banned until 15, 20 years ago. In some developed countries, people couldn't use metformin because we thought maybe it can cause significant side effects. But it was just bad press. There was no significant side effects. And now it's one of the most essential drugs on the WHO website. But we are learning a lot about this drug. I've listed lots of potential use for this drug. It could be effective for aging, cardiovascular disease, weight control, and so on. But at the molecular level, we are learning a lot about this drug. And there is clear evidence in vivo and vitro that it works as an anti-cancer cells. And it works for different types of cancers. I've given you some examples, say breast, colon, renal, and cell carcinomas. But when you look at the human studies, there is evidence that if you take metformin, then the rate of cancer is less. Your response to chemotherapy is better if you are on metformin and if you have cancer. If you have cancer and you are taking metformin, the metastasis rate is less. So there is also clear evidence in human studies that this drug works on cancer cells as well. Apart from the diabetes, it's also used for polycystic ovary disease. And I've listed some potential use here. A lot of my male colleagues have started using this because they try to avoid some of these possible complications. And when you look at the cellular level, we know this drug can work on this special pathway in the cells called mTOR pathway, mammalian target of rapamycin. This pathway, it's like a circuit in the cells. It works as a switch. We all have this pathway, and we all have this switch. If we need this pathway to be active, we let it go, it works, and it controls cell divisions and cell growth and so on. But when we don't need this pathway, for example, we've had enough lunch and so on, we are happy and so on, you can turn the pathway off. But unfortunately, some people, that pathway is constantly overactive because the switch is faulty. And that happens in individuals with this condition, tuberous sclerosis complex. Because they have faulty genes, that switch is faulty and the pathway is active constantly. So ideally, you need something to control the pathway to turn that switch off. Obviously, the pathway is much more complex. It's not just a circuit and switch, a light bulb. So what happens if this pathway is overactive? Because it's a very crucial pathway in cells in the body, when it's overactive, you produce lots of cells, lumps and bumps everywhere in the body. In the brain, quite often children present with seizures, learning difficulties, behavioral difficulties, because they've got this constant pathway and they produce these lumps in the brain. I put this MRI scan there for you to see. I'm pressing the right button there. So you can see they grow these big lumps in the brain because the cellular pathway is constantly active. There is nothing to control it. They have a lot of facial rash, as you can see there, facial angiofibromas, again because of that. And they get big lumps in the other organs, kidney, for example, there you can see this massive big lump there, bigger than a baby size, and lumps on the skin, nails, and so on. So it's a multi-disease, really, multi-organ disease. And it can be very difficult to control and can cause significant complications. And that's all because of this overactivation of the pathway. This place is very famous in the TSC world, and you've probably been there on holiday. This is Easter Island. It is fascinating because in this Easter Island, in the soil of this place, they found mTOR inhibitors. The mTOR inhibitors are called, the traditional ones are called rapamycin and everolimus. So everolimus is now licensed for TSC in the UK and elsewhere. So we can use it, but it's very expensive and it's a very powerful mTOR inhibitor. If you have TSC and if you take metformin, that costs nearly £40,000 per year per patient. And the significant side effects because it's a powerful immunosuppressant drug. Yeah, it can cause sepsis, it can cause mortality, and people have unfortunately died because of these drugs. So it's very powerful, but it does work, I have to say. But we need a cheaper option and safer option. When we use everolimus in patients, you can see this MRI scan there, you can see the white lump there. So that's a brain lesion because of the TSC. This patient received mTOR inhibition and the lesion got smaller. We stopped that, the lesion came back. We restarted again, the lesion got smaller. So no doubt it works very well for these tumors, but it can cause problems. And then we realized that, we discovered that metformin is also an mTOR inhibitor. And we felt, well, if it's an mTOR inhibitor, then it should work for TSC patients. Yeah. So we set up a study and was published some years ago in the Lancet Neurology. We used metformin in a small group of children and adults with TSC. And we want to know whether metformin has any effect on their lumps and bumps. Brain tumors, we call them subependymal giant cell astrocytoma, and kidney tumors, kidney angiomyolipomas or AML. It was a small study and we recruited nearly 50 patients in the UK. Oh, wait, thank you. I'm going to speed up. So the age inclusion criteria was 10 to 65, and all the patients had TSC. They all had kidney angiomyolipomas and so on. And we didn't know what dose to use because this drug was never used in any individuals in TSC. We decided to use the diabetic dose because we thought it's safe and has been used previously in both children and adults, therefore it should be okay. And NIHR was fine about that. This is the timeline of the study. We were specifically interested in the AML size, the kidney lumps, and the brain size lumps, and also the effect of this drug on epilepsy and some other comorbidities. So nearly 51 patients in the trial, half of them were receiving metformin, the other half were receiving placebo, sugar pill, for 12 months. And when we looked at the results at the 12 months endpoint, a lot of patients who were taking metformin had slower AML growth compared with the placebo group. So clearly the drug was doing something to their AMLs, but they're statistically not significant, and the sample was small, only 51 patients. But when we looked at the SAGA group, the brain tumor group, the results were significantly relevant and important, and it was quite pronounced. So those who were taking placebo had 30% increase in their SAGA volume, compared with 23% reduction in the metformin. So the difference between the two groups was significant. As you can see here, this line there, so anything below this line is a reduction in the size, the volume of the lumps. Anything above the line is growth. So this is the treatment group. This is the sugar pill placebo. As you can see clearly, there is a lot of patients had significant reduction in their brain tumor growth compared with this group. We hardly had any. But if you look at the natural history of this condition, so we've divided the groups in young people less than 30 and more than 30. If you look at just the placebo group, this is the kind of the natural history of the condition, yeah? So anyone less than 30, their brain lesion was rapidly growing in the placebo group. Anyone more than 30, the lesion was growing slower. And that's consistent with the natural history, because when you get older, the lesions tend to slow down. But the metformin group, you can see the significant reduction in the younger ones. So the take-home message was, the sooner you start, the better. You can prevent these complications. Because if you don't treat these lumps in the brain, they can cause significant problems, and people have lost their vision because of these lesions. The safety profile was absolutely fine. We didn't have any major complications with the drug. As you know, this drug is well known and it's very safe. Thousands and thousands of people have been using it over the years. But when we look at this epilepsy data, it was quite significant as well. A lot of people who were taking metformin had significant epilepsy or seizure reduction compared with the control, the placebo group. But it was a very small sample here. Then following this, we've approached our largest funder in the UK, which is the NIHR, and we're very lucky. We've been awarded approximately £3 million to do a national study, multi-center study in the UK to recruit children and young adults with TSC to assess the efficacy of metformin in these individuals. Our primary outcome is epilepsy. We want to know whether metformin has any effect on epilepsy. Again, this is going to be a 12-month study. Half of the patients will receive metformin and the other half will receive placebo. And we will be doing a lot of assessments during the trial and at the end of the trial. Obviously, epilepsy is our primary outcome, but we want to know a bit more detail about epilepsy frequency and severity, how many seizure-free days they will have at the end of the trial, whether they will need a lot of hospitalization due to epilepsy, and so on. We will be looking at other outcome measures. Quality of life is very important, sleep, learning, cognition, and so on. We will also look at the brain tumor size, the subependymal giant cell astrocytomas, and the kidney angiomyolomas. It's quite exciting, and we are very positive about this because we've got enough evidence from the pilot study that this is likely to be effective, but we want to test it in a bigger study and have larger sample. And we are hoping to recruit 130 patients over the next 5 years. We want to make sure that we are inclusive, and we want to make sure that children are recruited in this trial. And quite often you see, children are excluded in these trials. So it's important that they are part of this trial, and it's important that the drug is assessed in this population firsthand rather than inheriting results from adult population. We also want to make sure that adults are also represented in this trial, especially adults with learning difficulties. As you know, quite often people with learning difficulties are excluded from many trials, whereas here we have to make sure that they are part of the study. And as per the inclusion criteria, they need to have active seizures so that we can count the seizures, we can assess the efficacy of metformin in this trial. The exclusion criteria are generic like any other trials. We want to make sure that the patients are stable, they can tolerate the drugs, they can attend the hospital appointment, and so on. But we've tried to make the protocol as pragmatic as possible. There are not many hospital assessments and appointments during the trial because, quite often people with rare disease, with multi-organ disease, they have multiple comorbidities. It's hard for them and for their carers and parents to bring them to the hospital for these appointments, especially if they are in a clinical trial. So it's a very pragmatic, easy to deliver trial. Thank you very much for listening, and that's me for now.